treatment, one of the things that was revolutionary about that, because the first study to randomize was spearheaded by Victor Blanchette of Sick Kids, was that they allowed grade 3 hemorrhage to be included in the study. And what they found was that about 1 in 7 of the patients with grade 3 bleeding were later admitted and required treatment. So for me now, I would probably treat those at diagnosis, but not everybody would agree with this. In this study, of the 100 on no treatment, 8 had to be hospitalized and treated, and 1 had an intracranial hemorrhage. On the other hand, in the 100 who were given IVIG, only 1 was hospitalized for bleeding, but 5 had allergic or headache reactions to IVIG. What was very important in this study, which started back in 2009, was that no pre-medications were given for IVIG. And a recent study in 2020 from Sick Kids from Manny Corqueo showed clearly that if you give steroids with IVIG, you reduce headaches substantially and increase efficacy. And I believe this is very important. As we said, on the one hand, it's important not to treat patients who don't need it, but it's very important to treat those who do. And when you're treating the patients who may have increased bleeding, a single agent such as high-dose steroids or IVIG may not be sufficient, and you may need to combine multiple treatments. We looked at this in a different way in an article in Blood in 2007, but I think it's important when you're treating that you don't undertreat. Now, this is a study from Sick Kids also that I think is a landmark study about could you give steroids to children who have apparent ITP without a bone marrow? And in general, the answer is yes. And my take home from the study was that if they had typical ITP, meaning normal white count and normal hemoglobin, you could be quite confident that they had ITP and you would not miss any cases of leukemia. However, if you had cases with minor abnormalities and you said, oh, the white count was low because of a viral infection, or the hemoglobin was low because of bleeding, you would miss cases. And therefore, my only exception would be if you have somebody who has a history of bleeding and they have a low MCV, to emphasize that the degree of anemia is due to bleeding, I could see not doing a bone marrow, but otherwise they should do it. And the Pediatric Oncology group that merged with the Children's Cancer Study Group looked back at over 1,000 leukemia cases that had been entered in their studies and found that not a single one had presented with only thrombocytopenia. Okay, moving to treatments. We know IVIG is very effective. There's a number of things that have changed with IVIG. The reduction in anti-A and anti-B in some preparations means there's less hemolysis with it. The screening for factor 11A means there's less thrombosis with it. And the elimination of sucrose and certain other stabilizers means that renal damage is much less frequent. So it's potentially a little safer than we thought of. This is data from a publication of ours in the Journal of Pediatrics in 2017, and it points that if you're treating adolescent females with ITP, they have the only really good chance of being cured by rituximab with or without dexamethasone. And this has been confirmed in other studies in adults. So we consider that a marker to treat. If we're thinking about thrombopoietic agents, I think you all know there's a lot of data with romoplastin and L-thrombopag in children. There's long-term data only with romoplastin. There is, as of yet, no long-term data with eltrombopag, although there's an ongoing study from China that may provide it. This is our data that's been confirmed in recent study coming out again with romaplostin, that myelofibrosis is not an issue in children either. And this we published in the Journal of Pediatrics in 2014. And finally, in Petite 2, published in The Lancet in 2015, when a durable response was used, the kind you would like, consistent good platelets, the probability it would happen with eltrombopag was far higher than with placebo. What's different about using these agents in children, since still most of the publications are in adults? You can use often higher doses per kilogram in children. Dietary restrictions need to be observed, especially for eltrombopag, especially in teenagers and infants. And I think it's actually safer in children because you have a lower risk of thrombosis and a lower risk of an underlying myelodysplastic syndrome. Dr. Al-Jefri was kind enough to mention the original ASH guidelines. The 2019 one that I'll be referring to is the third one. It's important to realize that while there were adult experts in adult ITP and pediatric ITP, if they had participated in any studies and thus received support from industry, they had to recuse themselves from voting. So one of the odd things about these guidelines is that for the adult ITP sections, often the pediatricians dominated the voting, and for the pediatric sessions, the adult hematologist dominated the voting. And this is the composition of the group. Now, the panel generally had very few strong recommendations, and strong would mean that most individuals would adhere and very few would not. For all the recommendations, unfortunately, there's very low certainty of evidence. And conditional recommendations, which are the great majority, would be that the majority of individuals would adhere to them, but many would not. And individualization would be particularly important. And they had a specific statement for second-line therapy about the need to individualize, and they mentioned many of the different items. Now, what are some of the perspectives or clinical limitations? This is not a how I treat article, where it goes into exactly what to do in lots of patients and expresses opinions. And the dominant problem is you can't express a strong recommendation when the data is lacking. And another way to say that is that it's hard to use stringent, high-quality, evidence-based scoring systems in the absence of stringent, high-quality evidence. Also, the data entry was closed in, I believe, May of 2017. So fostamatinib is not to be used in children. Avatrombopag was not considered. And some of the newer studies, like the Tiki trial I presented to you that's so important, did not get included. These are the recommendations for children, and you'll see they're all very low quality of evidence. So, as we mentioned previously, if the platelet count is low, but there's no or very mild bleeding, skin manifestations only, the suggestion would be not to admit. And the same, but maybe stronger, so it's recommends as opposed to suggests if the platelet count is higher. But here they especially, they especially discuss the issues that if there's uncertainty of the diagnosis, if there's social concerns about the family, if there are those who live far from the center, for whom follow-up can't be guaranteed, it may be appropriate to admit. And I believe, at least in Riyadh, some of your patients would come from the outlying areas, and those might need to be admitted for those reasons. They also, for these similar patients, looked at treatment, and they would recommend observation over treatment if there was no or mild bleeding. And you see that there's no comment about the platelet count here. And for anti-D specifically, they made a strong recommendation with moderate evidence, but I'm not sure that's correct or should be differentiated. If there's significant bleeding but non-life-threatening, there's recommendation to use steroids, but the point here is not for more than 7 days. And the last study I will cite from sick kids is the study that Victor Blanchette initiated of giving 4 milligrams per kilogram of prednisone for a limited number of days, 4 days with rapid taper, that's similar to the way we use dexamethasone, and that was the recommendation here. So it's a strong recommendation, meaning the opinion was very consistent on it, but again, very low certainty of evidence. And prednisone rather than dexamethasone, steroids rather than anti-D, and steroids rather than IVIG. But as we said, if there is a patient who has significant bleeding, then I think IVIG would be considered and steroids would be good with IVIG. Finally, and I believe this is the last slide, for second-line therapy, it's really very hard to say what to use. I talked to you a little bit about where I would specifically use rituximab and the data in support of the thrombopoietic agents. I think the main thing you could take away here is that splenectomy is increasingly infrequently used in children with ITP. And I would turn it over to Dr. Jeffries. I'm unsharing my slides for his presentation.
Thank you very much, James, for this educational and helpful elements that you gave us in the lecture. I will again, I will request everybody if they can write their or prepare their questions so that we can answer them at the end of our session. So with that, I'll go ahead. I have 3 cases that I'm sure Dr. Bussel will have a lot to comment on, and maybe help us in whether this was the best approach or not. So I'll just proceed to the first case. These are cases, some of them we did long time ago and some of them recently. So the first case is a case, the 3-year-old girl who presented with petechiae and nosebleed for 1 day duration. Otherwise, patient had no symptoms, fever, weight loss, or preceding infection or illness. The past medical history was unremarkable, and the family history was unremarkable for blood disorders or any chronic illnesses. No drug history in that patient. At the physical examination, the patient looked normal with no physical abnormalities or skin stigmata. Vital signs were normal, height and weight were appropriate, head and neck examination was normal. Chest exam, lungs and heart were normal and clear. Abdomen, unremarkable, no lymphadenopathy, and as I mentioned, no organomegaly. And the rest of the examination was unremarkable in this kid. Lab, the white blood cells 7.4 times 10 to the power 9 per liter. Hemoglobin was 12 grams per liter. And the platelets were 7,000. The differential of the white blood cells was unremarkable. The peripheral blood exam, there was few large platelets. The renal and hepatic function were within normal. Immunology and rheumatology tests were done, and immunoglobulins were normal. The Coombs test was negative. ANA and anti-DNA, rheumatoid factor, ESR, anti-cardiolipin, lupus, anticoagulants, they were all negative. Mind you, these cases, when they are referred to King Faisal, we have to take the extra mile and do the extra work that was done. Presumably, these patients are not the straightforward ITP that one would think of. That's why we are doing these extra tests in our center. So management-wise, the patient was given IVIG, 1 gram per kilo per day for 2 doses. The platelet went to 22,000, and on the third day to 54,000. 4 weeks later, the platelets were 40,000 on follow-up, and 6 weeks later, there were 17,000. So a bone marrow aspirate and biopsy was done, and the marrow was cellular with increased megakaryocytes and no abnormal cells were seen. So a patient was started in prednisone 2 milligram per kilo per day as an outpatient management, and was monitored with lab work. Platelets went to 43,000, and 2 weeks later there were 120,000. The steroids were tapered over 4 weeks period and was discontinued. On follow-up, patient developed recurrence of bleeding in the form of epistaxis after 3 months. Platelets at that time were 10,000. Patient was treated with IVIG, 1 gram per kilo per day for 2 doses. And there was prompt response of platelets to 220,000. And steroids were also resumed with 1 milligram per kilo per day and slow taper. Eventually, patient was, after the tapering, maintained on 5 milligram every other day for 4 months and then discontinued. 2 months later, the patient has a recurrence of severe bleeding and came to the hospital where he required resuscitation with platelet transfusion and IVIG and high dose of steroids. At that time, a decision was made to do an emergency splenectomy and managed to have a laparoscopic splenectomy. And promptly after the splenectomy, platelets rose to 680,000. Patient was observed and continued to be followed closely. And 2 months later, his platelets count dropped to 30,000s. Management-wise, again, he required short courses of steroids and IVIG for his symptoms. Of course, the patient developed side effects of steroids with time, and rituximab was given in view of the refractiveness and chronicity of the disease. He had 4 courses, 4 doses of weekly rituximab, and the platelets rose to 60s to 80s thousands in response to rituximab. Patient was started also on mycophenolate mofetil and with occasional IVIG for episodic bleeding, and gradually weaned off immune suppression over 16 months. So that's the first case. The second case is
Professor Al-Jefri?
Yeah, please.
Would it be okay if we discussed case 1 before you move on?
Sure.
Is that okay?
Yeah.
First, I totally agree with what you said about doing the workup, in that we did an extensive workup for secondary ITP and other non-ITP like you did for exactly the same reason. If somebody's being referred to you after having been elsewhere, you're concerned it may be a difficult, complicated case and you don't want to miss something. I couldn't agree more with that. I think doing the splenectomy in this particular case made a lot of sense. You're having somebody you're trying to manage, you can't seem to manage them successfully, and you just have to do something that you hope will work. And it's unfortunate in this case that it didn't. I think it's also unfortunate, and I'm happy to hear your thoughts, that we can't predict response to splenectomy very well. You know, we don't have a test that, oh, this person will respond, that one won't, and whatever. So the other thing I would say, it was interesting to me that the second response would have to IVIG seemed better than the first. And I would have thought, and I think maybe you did, that the patient was getting better and would do well, and that, you know, that would be a longer, slow taper of very low dose steroids would work very well. And I think you and I was disappointed reading the case that that didn't happen. After that, though, what you do, it's hard to know. And I think what you did seems to have worked out remarkably well.
Right, you're absolutely right. Again, you know, the splenectomy, and especially in young age, we try to avoid as much as possible. But in view of having, you know, symptomatic bleeding, active bleeding, it's not wise to waiting for a response by steroids or a third, you know, rituximab, for example, third line. So we elected to go with that, hoping that the splenectomy may give a long-term increment in the platelets. But as you saw, you know, and after 2 months, the platelets again started to come down, and you know, management-wise, we have to, you know, the steroids and IVIG just to induce some sort of improvement in platelets. Now, eventually, we thought that, you know, why not to try, you know, MMF to see if it's going to induce, you know, reasonable or maintains, you know, adequate platelet count. And it looks like it worked for some time until we were able to wean it. Now, this patient did not have optimal platelet count, but again, safer limits of platelet count, you know, in this patient.
Let me mention just one thing. One of the most interesting abstracts presented at ASH last month on MMF, though it was in adults, compared MMF plus steroids to steroids alone at diagnosis for adults with ITP. And the adults started with MMF and prednisone had a better response by about 20%, 10 or 20% for discontinuing all therapy. And I think MMF has become a very popular, appropriately so, treatment. So this was greeted with great enthusiasm. So I think MMF was a great choice.
Yeah, and thinking about it, this might not be, as you mentioned, you know, a fraction of those ITPs may not be genuinely ITP, you know, primary ITP. So, you know, we had patients who, you know, you expect that there must be some secondary ITP, although we did all the investigation for this case. And some of the patients, for example, we have patients with ALPS who did well with MMF for not all of them, but some of them. So fortunately, in this case, we managed to continue on MMF. So that's what happened with this patient. So with that, I'll go to the second case, which might be a straightforward ITP, hopefully. A 10-year-old girl who was referred again for recurrent refractory ITP from a local hospital for further evaluation and management. This patient presented in the local hospital at the age of 5 years with recurrent epistaxis ecchymosis of 1 week duration. The symptoms were preceded with viral URTI, which is a common cause for ITP. There was no fever, no weight loss or bony pains, no family history of blood diseases, and no consanguinity. On examination, well looking, no pallor, no jaundice, and no lymphadenopathy. Lungs and heart were normal, abdomen, no palpable spleen or liver, and no other masses, and no lymphadenopathy, as I mentioned. CNS conscious and normal tone and reflexes. Investigation, the CBC showed 6.4, 10 to the power 9, with normal neutrophil count and no abnormality in the differential. Hemoglobin was 11.9 and platelets were 3,000. Renal function, hepatic function, Coombs test, all were negative. ANA was negative. A bone marrow was done, was normal cellular with hyperplasia of the megakaryocytes, no abnormal cells, and flow cytometry was negative for malignant cells. Viral screening was done, EBV, CMV, HIV, and the hepatitis C and B were screening was all negative.
How did Professor Al-Jefri?
Yes.
How did you do the screening for the viruses? Because I believe very strongly, when possible, that doing PCR or testing to prove the presence, as opposed to antibody, whether it's been in the past or whatever, is very important.
We did the antibodies for hepatitis C. We did the screening, the surface antigen, and the antibodies for the B. But for C, we did just the antibody screening, just to see if there is.
What about for CMV and EBV?
CMV, we do the PCR for CMV, and EBV quantitation, we do it. So these are the tests that we rely on.
Very important, I think.
Yes, I think this is for the audience also to take in consideration. Again, as I mentioned, that after the steroid dose, 4 milligram per kilo for 4 days and tapered over 3 days, there was a good response of 98%. 2 weeks later, the platelets dropped to 16,000, giving IVIG 1 gram per kilo. For 2 days, the platelets rose to 49,000. Patient since then required repeated courses of steroids and IVIG for the drop in the platelet count and bleeding symptoms. At King Faisal Hospital, again, we did the extra tests, the C3, C4 immunoglobulins, the autoimmune disorders were all done, including the immune deficiency disorders were all done, just to confirm that the patient doesn't have underlying cause for this immune thrombocytopenia. A bone marrow was also done, confirmed, and was consistent with peripheral destruction and megakaryocytic hyperplasia. Over a 3-year period, the patient continued to have, on and off thrombocytopenia, but there was no major bleeding in the patient. IVIG was given for symptomatic bleeding. The patient, again, we continued to have these repeated steroid therapy courses. However, the response was suboptimal in these patients. So we started L-Thrombopag for this patient on May 2018, and I will show you the graph of the response to the L-Thrombopag. We started with 50 milligram daily, not per kilo. with significant improvement in platelet count, and the response continued following while on treatment. We tried to taper the L-Thrombopag to 25 milligram daily. However, the platelets dropped down, and we resumed the 50 milligram again. The last time the patient was seen on 16th of December 2020, and the platelets were 254,000. And as you can see here, the graph of the platelet count, from the time of referral to our hospital. As you can see, this is the limit of the 100,000, and as you can see, it started to be low, and these episodes require repeated doses of steroid and IVIG. And here we started the L-Thrombopag on May 2018, and slowly you can see the response going up and continued to be high, at least above 100. And as you can see, these peaks, however, all readings were 100,000 and more. Any suggestions or comments, James?
The only comment I'd make is, I think the patient must really appreciate having a stable count. I don't know if she's old enough to be menstruating yet, but if that was an issue, it would definitely probably help her to have a stable count, to not have heavy bleeding. And the only other thing I would say is, sometimes when you're tapering or adjusting the dose, like you did from 50 to 25, and the count may fall, it may require smaller movements. And I think we're all trying to figure out, sorry, last point, in somebody like this, could you taper it off and stop it altogether? And could the count remain greater than 50,000, anyway, so that you would feel okay about it? And it's very hard to know, and no markers to predict that.
You're right. Now we're limited by the dose of L-Thrombopag of 25 milligram. This is the lowest you can give. But, what we used to do is that any patient who's less than 6 years, we give 25 milligram. Anybody who's above 6 years, we give 50 milligram. And again, until you have some time, you pass after some time, you may consider going slowly with trying to wean. However, we know that not all the patients will be able to completely. You can take them off the TPO receptor analog or agonist. Now, what do you do if this patient, let's say, or any female reach her menses, or you give hormonal therapy to stop it?
If you need hormonal therapy, the main thing I would say is progesterone-based hormonal therapy will help the ITP. There's a lot of scattered small data demonstrating that. Estrogen-based hormonal therapy may worsen the ITP. So typically, it would try not to just use estrogen if that was needed. If it were possible, meaning if the woman was willing to accept it, and if she was pubertal, you would assume that her growth was pretty much done. You could actually try to use danazol, because that would take care of the bleeding and help the platelet count. But as I'm sure you know, it would give you a certain amount of acne, certain amount of facial hair, and many women would not want to take it. So I think whether just controlling the platelet count or hormonal therapy, it all depends. I wouldn't necessarily try rituximab in somebody like this, mainly because she's had the disease for a long time. And I think when you're very chronic, she may respond to rituximab, But like the other treatments, it's much more likely she'll relapse in a little while and have the ITP come back instead of being cured.
Okay. Okay. Now the third case is a patient not primary immune thrombocytopenia, but likely to be genetically determined autoimmune thrombocytopenia. This is a 4-year-old boy diagnosed with DiGeorge syndrome, so chromosomal deletion, which involves, cardiac, other developmental delay, immune deficiency. This patient has cleft palate, was repaired, seizure disorder, and mild pulmonary stenosis. At the age of 1 year, he developed multiple bruising, active epistaxis, and gingival bleeding. His platelets were 29,000 and slowly came down to 2,000. At that time, we were consulted during this time to deal with the patient. Patient in general pediatric was transfused with platelets. However, there was no response or poor response. We gave IVIG 1 gram per kilo for 2 doses, and there was poor response, 14,000, 16,000. Bone marrow was done, showed increased megakaryocytic cells suggestive of peripheral destruction. So we started steroids 2 milligram per kilo and continued on steroids with 1 milligram with some improvement in platelets count. The response was suboptimal. He continued to be managed with IVIG and steroids. At this time, we gave pulse steroids of 30 milligram per kilo per day and platelet transfusion to control the bleeding. And he was maintained on 1 milligram per kilo per day. However, the response was also poor, with platelet count is suboptimal, and he came again with platelet count less than 10,000. We continued to manage him with IVIG. This time we gave 3 doses, and we gave methylpred 4 milligram per kilo per day. Again, platelet count was really poor. There was poor response. We thought to repeat the bone marrow again to see if there is anything going wrong. It was the same picture with active megakaryopoiesis and normal other lines. So he was started in thrombopoietin receptor agonist. This time we started with romiplastin. We started with 2 mics per kilo per week subcutaneously, and this is given weekly. We started on 8 May 2018. And there was some improvement in platelet count. However, there was fluctuation with the platelet count and needing adjustment of the dose. So we continued to increase the dose until we reached 8 to 10 mics per kilo per week. Only then we were able to attain platelet count above 100,000. This patient has to move outside Riyadh, and so we had the choice of giving L-Trombopag. So we gave 25 milligram per day orally, and started with September 2019, and patient was monitored at his local hospital in Taif, and he was seen in our clinic every 2 months. So before that, he used to come every week to receive his subcutaneous injection of romiplastin. Now, since we started L-Trombopag, he maintained platelet count above 100,000 with no issues or problems or bleeding, episodes. The last time he was seen was on 12th of February 2020, and he was doing well with no history of bleeding. His the CBC showed platelet count of 168 while he was in 25 milligram of L-Trombopag. So again, this is the graph of the platelet count. As you can see here, he had very low platelet count when he required active management with first line, IVIG steroids, and have multiple doses, continued to have, low platelet count. Here, as you can see in this white circle, when we initiated Ramiplastin, as you can see, there was a good increment of platelets that continued. However, we had to change the dosing and increase the dosing because of these drops. Mind you that you cannot change the dosing except to wait 1 week and then go with a higher dose. As you can see here, we started L-Trombopag in September, and then as you can see, the counts continue to be a good range with no fluctuations. All of it was more than 150,000. So this is the graph that shows the response to therapy in this patient. I think this is the end of the cases. I'll see Dr. Bussel if you have any comments.
Only comment on that is it was really good that you picked up that there was something else going on. And I believe one of the things you were sensitive to as listening to the case was that this is a patient especially who should not be on any chronic immunosuppression because he already has an underlying immune deficiency with DeGeorge.
Absolutely, you're correct.
And I think it's well known in ITP that you get much more cycling with Romoplastin because it's given once a week, we believe, even though the mechanisms may be slightly different. So sounded great to me.
Yeah. What do you think, James, for using the Ramiplastin? Is there any problem with going with higher doses than to start with 2 mics? Have you seen any complications that are attributed to the receptor analog? Or you can go with 5 mics, for example, rather than to wait all this long.
I think in ITP with Romoplastin, the theoretical limit is 10. And with L-Trombopag, the theoretical limit is 75. As I know in aplastic anemia, they go up to 20 with Romoplastin, and they go up to 150. These would be in adults with L-Trombopag. So in principle, you could go higher. We often would start at a higher dose in somebody where it was bleeding or very important to bring the count up, maybe even 5 or 7 mics per kilo of Romoplastin, especially, very occasionally 75 with L-Trombopag.
Okay, I think we'll go to questions if you allow me, James.
Sure.
So this is a question from Dr. Let me just see. Is it showing there or? Let me just see. I'm trying to show it. It says, I think I lost the question.
There's a question about type 2B von Willebrand.
Yeah.
For ITP. Would you like to answer that, or would you like?
No, go ahead, please, go ahead.
One of the things that characterizes type 2B thrombocytopenia is it fluctuates anormally based on stress and on estrogen use. So you ought, I think, to be able to make the distinction. As far as other bleeding disorders, I've seen patients, especially with factor 11 deficiency in ITP or who have von Willebrand, and fortunately, they don't actually seem to bleed excessively, but it's obviously very variable. If they have type 2, you can have type 2 either because it's based on the von Willebrand factor having too high an avidity for the receptor, or it can be an abnormality in the platelet GP1B9 receptor with too high an avidity. And the only importance of that is if it's an abnormal von Willebrand molecule, you need the normal. And if it's an abnormal platelet receptor, you need to flood the system with normal platelets. But fortunately, it's very rare and should be relatively manageable as far as I can tell from the question. I don't know if I missed something else.
No, that's good. There is a question from Dr. Yahya Ghazwani. How earlier thrombopoietin agonists could be used in acute persistent ITP? Or how early you can start?
In the adult area, recently romoplastin was licensed for any time after diagnosis, as long as the patient has failed one therapy. That's brought on by the comments about steroids, which you saw even in pediatrics, not more than 7 days, and in adults, not more than 6 to 12 weeks, meaning if the patient still needs therapy, you have to go to second-line therapies earlier. I think it all depends. The so-called ICON group, ITP Consortium of North America, is doing a study now for children with ITP who need treatment, essentially at diagnosis, randomizing between standard of care, which would be largely prednisone, versus standard of care plus L-trombopag. And that was greatly delayed, unfortunately, by COVID, but probably should finish in another year or two, and that would help tell us what are the advantages and disadvantages.
Okay, there is a question, I think it's a good question. Is molecular genetic test is recommended for difficult cases of ITP? I think this is something that one would assume that you may have to do it if you don't get a good response. What do you think?
Sure, I think it would help, but I think it not as productive as it could be in other settings. But certainly that's one of the things to do, and we had recommended that in our article. If you can't do something simpler that might tell you what the cause is. Mm-hmm. Part of that is if it's really ITP and it's not obvious secondary ITP like Professor Al-Jefri, your case 3 with DeGeorge, the molecular genetic test may or may not help you know how to change the treatment. Mm-hmm. So if it's a chronic difficult thrombocytopenia, yes, definitely. And again, that's someone who you should look at the smear again on.
Mm-hmm. I totally agree. I think in our community or in our population, you know, if it happens in young children, you know, especially in the first year, second year, and you don't get the classical response, even if there is megakaryocytic hyperplasia, you would assume, because I have few patients who did not respond favorably to the classic management. And these patients turned out to have underlying genetic disorder. So keep your suspicion there.
One thing, in certain parts of New York, like in certain populations of New York City, and I believe in certain populations in Saudi Arabia, the rate of consanguinity is relatively high. So you would commented on that in one of your cases. So right. If there was any thought of consanguinity, I think that would make it more likely that you could find something.
Exactly. We had few cases of unusual autoimmune diseases, immune deficiencies, who eventually happen to have underlying genetic disorder, and they need to be referred to this specialist, either in rheumatology or in immunology, to work them up. So I think with that, I think we're reaching our 9 p.m. Probably. 10 p.m. That's 2 o'clock at your time, Jim. So I would like to thank Dr. Bussel for participating with us and enlightening us from his experience, wide experience, 47 years of experience in this field. Is quite prominent. And I would like to thank the audience for attending with us this session. We try to make it interactive during our cases so that we can learn from the actual life management. And again, I would like to first to announce the upcoming webinar is going to be in how I treat myelofibrosis with Professor Francisco Basmonti and Dr. Ahmed Al-Saeed, who's going to be with you on 23rd of January. With that, I'll conclude, and I thank Dr. James Bussel for sparing